First of all, definition of asthma. It is a chronic respiratory disease, involves airway inflammation, intermittent airflow obstruction, and bronchial hyperresponsiveness. The Global Initiative for Asthma, GINA, defines asthma as heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory flow limitations. Now, what are the risk factors for asthma? Prenatal and perinatal factors. Maternal vitamin D deficiency have the risk of asthma in offspring. Active smoking and exposure to environmental tobacco smoke, and maternal and early childhood use of certain medications like acetaminophen, acid suppressive medications, and certain antibiotics. Childhood risk factors. Childhood asthma affects males more than females. At early adulthood, incidence is about equal. By age 40, more women than men have asthma. It is more common with other atopic diseases. Exposure to bacteria and bacterial products may influence the development of allergen sensitization and asthma development. Adolescent and adult risk factors include tobacco smoke exposure, allergic rhinitis association, occupational exposure to noxious aerosols, patients with increased body mass index, house dust mites, cat and dog allergens, cockroach allergens, and fungi. Aspirin or NSAID hypersensitivity. What is pathophysiology of asthma? First of all, it involves airway inflammation, then intermittent airflow obstruction, and bronchial hyperresponsiveness. In airway inflammation, it can be acute, subacute, or chronic. Some of the principal cells identified in airway inflammation include mast cells, eosinophils, macrophages, epithelial cells, and activated T lymphocytes. T lymphocytes play an important role by releasing various cytokines. Chronic inflammation of airway is associated with hyperresponsiveness, which leads to typical symptoms of asthma like wheezing, shortness of breath, and cough. In intermittent airflow obstruction, it can be caused by a variety of changes, including acute bronchoconstriction, airway edema, chronic mucus plug formation, and airway remodeling. Third pathophysiology mechanism is bronchial hyperresponsiveness. Now, clinical features include wheezing on expiration, cough, shortness of breath, chest tightness or pain, using accessory muscles for breathing, episodic symptoms with characteristic triggers. How to diagnose? First of all, pulmonary function test. A reduced ratio of FEV1 to FVC when compared with predicted value, it demonstrates the presence of obstructive pattern. If after giving short-acting beta-2 agonist, FEV1 is more or equal to 12%, it is asthma. If FEV1 reduced less than 10% after short-acting beta-2 agonist, it is COPD. Complete blood count shows blood eosinophilia greater than 4% or 300 to 400 per microliter. Serum IgE levels can be greater than 100, and chest X-ray shows hyperinflation of the lungs. Treatment. The goals of treatment include to reduce impairment from asthma and attenuate the risk of adverse outcomes associated with asthma like hospitalization, loss of lung function, to minimize adverse effects from treatment or medications. Now, what are the GINA guidelines for asthma treatment? Step 1 include if patient is having infrequent asthma symptoms like less than 2 times per week, Therapy include low-dose inhaled corticosteroids with rapid onset, long-acting beta agonists as needed, or low-dose ICS whenever short-acting beta agonist used, or as needed low-dose ICS and SABA. In step 2, if asthma symptoms or need for inhaler more than 2 times a week, then therapy include low-dose ICS and formoterol as needed. It is a preferred therapy, or low-dose ICS daily and SABA as needed. In step 3, if patient symptoms include troublesome asthma symptoms most of the days, nocturnal awakening due to asthma equal to or more than 1 time a month, risk factors for exacerbations are there, then therapy include low-dose ICS formoterol as maintenance and reliever therapy like budesonide formoterol. It is a preferred therapy, or you can give low-dose ICS LABA combination daily and SABA as needed. In step 4 to 5, in severe asthma which is uncontrolled on having 3 or more than 3 of the followings: daytime asthma symptoms more than 2 times a week, nocturnal awakening due to asthma, reliever needed for asthma more than 2 times a week, activity limitation due to asthma or an acute exacerbation of asthma. In step 4 therapy include medium dose ICS formoterol as maintenance and reliever therapy, or medium dose ICS and LABA daily and SABA as needed. In step 5 therapy, medium dose ICS formoterol as maintenance and reliever therapy plus LAMA, or medium dose ICS LABA plus LAMA daily and SABA as needed. Assess asthma phenotype and evaluate for possible addition of asthma biologics. Thank you.